One table in a Palmerston North restaurant becomes a point on a public health map. The plates are gone. The people have gone home. Nobody can see a virus in the empty room, yet the date and time matter, because a person with measles may have shared the air with people they never met. The map becomes easier to read once one definition is clear. Eliminating measles does not mean the country will never record another case. It means the virus has not maintained a chain of local transmission for 12 months or more. Every new case starts a race to stop that chain. In July 2026, health officials investigated a measles case in Palmerston North that had no known link to international travel. The person may have been exposed while visiting Wellington around Matariki. Officials published locations of interest, including a high-risk event at Rosie O'Grady's. That news can sound as if elimination has failed. It has not, by itself. To understand why, separate three words: control, elimination, and eradication. Control means reducing illness to a level a country is working to manage. Elimination means stopping continuing local transmission in a defined place while maintaining strong surveillance. Eradication would mean ending transmission across the world. Measles has not been eradicated. It remains common in parts of the world, so an infected traveler can carry it across a border before feeling ill. A country can therefore eliminate local measles and still receive imported cases. New Zealand was verified as having eliminated measles in 2017. The official definition requires no endemic transmission for at least 12 months and a surveillance system able to find and investigate cases. New Zealand maintained that status even while recording 14 cases in 2023 and 1 case in 2024 because those cases did not produce a chain that continued for a year. The number 0 is not the whole test. The broken chain is. That explains the intense work around one restaurant, ferry, school, airport, church, or supermarket. Public health staff begin with time. Measles symptoms usually appear about 10 to 14 days after infection. A person can spread the virus before the rash makes the illness obvious. Officials therefore rebuild the person's movements during the infectious period. They ask where the person stood, how long they stayed, and who may have shared the space. Some people can be contacted directly. Others are strangers, so a location of interest becomes a public message. The location is not being blamed. A restaurant has not failed merely because an infectious person ate there. The notice is a way to find people connected only by air and time. Measles makes that search unusually urgent. It is one of the most infectious diseases known. In a population where nobody is protected, one infected person can pass it to roughly 12 to 18 other people. The exact number changes with behavior and setting, but the lesson is stable. Small gaps in immunity can support fast spread. Vaccination breaks many possible links before public health workers ever need to trace them. 2 doses of the measles, mumps, and rubella vaccine protect about 99% of people against measles. To prevent sustained spread across a population, protection needs to be very high and well distributed. New Zealand's planning has used a target of at least 95% coverage. The words well distributed matter. Imagine a national average of 95% created from one community at almost 100% and another far below the target. The average looks strong. The second community still contains enough unprotected people for a virus to move. Babies who are too young for routine vaccination, some people with weak immune systems, and people who cannot receive a vaccine depend partly on the protection around them. An immunity gap is therefore not only a private risk, it can become a route through a household, classroom, workplace, or gathering. The national schedule uses 2 doses because not everyone develops protection after the first. In New Zealand, people are generally considered immune if they have documented evidence of 2 doses given after 12 months of age, have had measles before, have a blood test showing immunity, or were born before 1969. Personal circumstances can differ, so a health professional or official public health notice should guide the decision. What should a person do when a location of interest appears? First, read the advice for that exact place, date, and time. Different exposures can carry different instructions. Second, check immunization records rather than relying on a childhood memory. The record may be in a well-child book or held by a medical center. Third, watch for the group of symptoms: fever, cough, runny nose, sore red eyes, followed by a rash that usually begins on the face and moves down the body. If measles is possible, phone a health provider before arriving. Walking into a waiting room without warning can expose babies, pregnant people, and patients with weaker immune systems. The phone call gives the clinic time to arrange a safer assessment. These actions are not proof that every exposed person will become sick. They are ways to remove possible links from the chain. The same idea explains why surveillance is part of the definition of elimination. A country cannot claim success simply because it stopped looking. It needs laboratories, clinicians, records, contact tracing, and people who respond to public notices. Finding a case can be evidence that the system is awake. The empty restaurant table is one point in a chain that public health workers are trying to end. The table may lead to no further illness. That quiet result is easy to miss because nothing happens. For measles, nothing happening is the achievement. Elimination is not a wall that keeps every case outside. It is the work of making sure each arriving spark finds no path to become a fire.